Good evening. I'd like to ask you to please mute your mics now. You'll have the opportunity to put your questions in the chat, and our panel will answer as many as they can at the end of the presentation. Welcome to Know More, a conversation focused on timely social issues and hosted by Leading Ladies. Leading Ladies is a nonpartisan social activism group based on the Massachusetts North Shore, and we care about access to education, climate change, fair wages, food insecurity, gun violence, healthcare, homelessness, humane immigration policies, racism, and inequality. Tonight, we will discuss life after Roe v. Wade. The moderator for our panel is Sara Stanley, Executive Director of HAWC, Healing Abuse, Working for Change. She joined the organization in June 2015 as Attorney Director of Legal Programs and was promoted to Executive Director in July of 2018. In this role, Sara is responsible for day-to-day leadership for the agency. Previously, Sara worked as an attorney at many firms and served as a pro bono attorney with the Women's Bar Foundation. The role at HAWC truly merged her interest in the intersection of domestic violence and the law. Sara obtained her legal degree from Suffolk University of Law in 2007. Please welcome Sara Stanley.
Thanks so much, Therese. Thank you, Judy and the Leading Ladies Executive Committee for hosting this event. I'm honored to be your moderator tonight. We are experiencing a dramatic attack on human rights and healthcare. Thank you for being here to know more from two incredible experts. Fair warning, the goal of tonight is not to assuage your fears or comfort you. On the contrary, what you learn here tonight may cause you significant consternation. What you will gain from tonight's discussion, however, is critical information about the legal and logistical realities we are facing and what we can do to fight for reproductive justice and abortion care. I'm thrilled to introduce our two experts here tonight. First, Professor Carrie Baker. She is the Bauman Chair for the Study of Women and Gender at Smith College. She has a BA in philosophy from Yale University, a JD from the Emory University School of Law, a Master's of Arts and Doctor of Philosophy degrees from Emory's Institute of Women's Studies. She's a contributing editor to Ms. Magazine and has published 3 books, including The Women's Movement Against Sexual Harassment, which won the National Women's Study Association's 2008 Sarah A. Whaley Book Prize. Welcome, Carrie.
Thank you so much. Great to be here.
Great. And next we have Kristie Monast. She is the new Executive Director of HealthQ, formerly known as HealthQuarters, a major sexual and reproductive health provider here on the North Shore. Kristie has a BS in biochemistry from Russell Sage College and a master's in education in human sexuality from the University of Pennsylvania. She is the principal and founder of KM Consulting and Training, and she served as the first executive director of Midwest Access Project, a nonprofit organization dedicated to filling the gaps in medical education and clinical training. Prior to that, she had an 8-year tenure with Planned Parenthood of Northern New England as a regional trainer manager and site manager. Welcome, Kristie.
Thank you, Sara. It's a pleasure to be here. And thank you, Judy and Therese and Leading Ladies.
All right, so we are going to hop right in, folks. We have so much to talk about. Carrie, can you start us off by setting the stage for us? What is the legal status of abortion as a result of the Dobbs decision?
Yes, absolutely. So on June 24th, the U.S. Supreme Court handed down a decision the decision of Dobbs versus Jackson Women's Health Center, which overturned Roe versus Wade, which for the last 49 years had guaranteed right to access abortion health care throughout the United States. The impact of Dobbs is it threw the decision back to the states. And right before I got on, the current tally is that abortion is totally banned in 12 states. There's a 6-week ban in Georgia. There are bans coming in West Virginia and Indiana. Both of those states have passed bans since Dobbs. There are later bans, 15 weeks, 18 weeks, 20-week bans in other states, and there are that are in effect. And then about another 9 states have bans that are blocked by court decisions but could go into effect. Right now, 14 states have protected abortion rights, and Massachusetts is among them. And another 8, abortion is legal, but it's limited. So basically, when all this is shaken out, abortion will be banned in over half the country. And 33 million women of childbearing age will live in those states where abortion is banned. Dobbs will make it harder to access abortion and cause people to have to travel long distances to get in-clinic abortion health care. For example, I'll just give you a couple examples. In Alabama, before the ban went into effect, the average one-way distance to get to an abortion clinic was 26 miles. Post Dobbs and with the ban in effect, it's now 327 miles one way. In Louisiana, it went from 37 miles to 666 miles, and that's just one way. Half of people who seek abortion health care live in poverty, and 75% are low income. They are not going to be able to travel these long distances. Half already have children. So how do you drive 666 miles, with the kids in the back, or days of having to pay for childcare when you're already living in poverty and low income? It becomes an absolute barrier to abortion, at least in clinic abortion. So I'll say more about the decision and the implication of the decision, but that's where we are right now as far as the law.
Great, thank you, Carrie. So Kristie, we're going to come to you next. We just heard a little bit about the typical abortion patient. Can you kind of zoom us in on what it's going to look like for patients trying to access abortion care in Massachusetts and nationally?
Absolutely. I do have a few visuals that I'm going to share, but I will start by saying that I've spoken with Carrie a few times, even in preparation for today, and every time she speaks, it gives me chills, right? It's a little startling to hear the reality that we know is in existence. And I will also say that I started my position here as executive director in January, and I moved from Illinois, where that state was surrounded by states we knew were going to be impacted. So I've been feeling this force for a long time, and it is quite devastating to be in the middle of it. So to answer Sarah's question, I'd say from the ground, some of the impact of what you're hearing from Carrie is, how do people access abortion care? I'd say that one of the biggest things that's a challenge right now is the misperception or the misinterpretation of media stories and how folks are interacting with where they get their news, so that most people are thinking that abortion is illegal, right? They're not sure if it's legal in their state, if it's illegal everywhere. And that is one of the first barriers, is just trying to relay to folks that abortion is legal where it is, or not, and that there are barriers that they're not expecting to face when they're trying to seek the care in their home region. The second thing is that there has been a lot of preparation, but with the leak in May, and between that and June of hearing devastating way that we now are experiencing this decision, some of the plans that were being put in place by abortion providing community have started to divert and go a little bit of different directions in that, we're trying to figure out how to help the most people get access to care and to get centralized, trusted ways to interact with where is abortion legal, what are the barriers that they're gonna face, where it is actually still legal, but there are barriers in place, like waiting periods, like parental notification or consent requirements, like mandated ultrasounds, and things that may say, one of the things that Carrie was referencing was that distance in traveling. Well, if you are having to travel in the closest state that you can get to has a 24-hour waiting period and they have to see you in person, have a visit with them, wait 24 hours after that first initial visit, then go and have your procedure, that's adding time onto an already complex system and the logistical hurdles, right, of childcare, of where are they staying, how do they pay for lodging, all of those barriers. So I do want to give a little quick introduction. Oops, first I need to choose to share this. I want to go to a slide where I have just a map of Massachusetts providers, and we'll start with this. In Massachusetts, I have a couple of pins on a map, and they're different colors based on who the abortion providers are in Massachusetts. And I'm going to use this as an example for the rest of the country, but this is reality of what access looks like in Massachusetts right now. So the red pins are independent health center systems like Planned Parenthood, like HealthQuarters or HealthQ, our friends Four Winds in Attleboro. And then the purple pins are hospital systems. There are a couple of places like Springfield actually has a red and a purple pin. Boston has more than just one red pin, but those are where folks can go to access abortion care. And you will notice that there are large swaths of the state that are not covered with a pin, right? The Cape, the islands, Western Massachusetts, folks still have to travel large distances within our own state here of Massachusetts to access abortion care. Carrie and I are both going to reference and talk about medication abortion and being able to do that by telehealth and not having to be in person. So I want to add that what's not represented here are specific, which ones of our red and purple pins offer telehealth medication abortion, but there are also other additional national organizations that are offering medication abortion that they're doing via telehealth. So people in Massachusetts can access them from anywhere they are in Massachusetts. And that does help with that travel disparity. And then I'm going to just move on to this slide, which shows the neighboring states. I have an extra color on a pin, but it represents all of the states in New England. And we're seeing that with the red pins, those are still the independent systems, but additional blue pins, which are independent health systems that offer medication abortion only. And then again, the purple pins that have the hospital systems that offer abortion care. You'll see like up in Maine, the majority of care is medication abortion only. People still have to drive a great distance to get to somewhere where they can access a procedure. I am sure that there are hospital systems that offer abortion care, but they do not publicize or make it well known. So there are no purple pins in Maine. And you can see that there's even a more dense, I wanted to highlight the disparity here. So that is Maine, but then in Connecticut, there's much more denseness where people don't have to travel as far for care, and there's much more variety in the colors of the pins, meaning that they have access to multiple systems for abortion care. The other thing I'd like to say in just sort of follow up to where Carrie started us is, depending on where people are gestationally in a pregnancy and how they need an abortion or would like to have an abortion, is something that in a lot of the country, especially in states where you see like that large swath in Maine, where people may not have access to what they want or what they need. So what's not represented by these pins is how far gestationally in a pregnancy can that location terminate the pregnancy. Does somebody have access to a sedation option if they want to be under anesthesia or they need to be under anesthesia? So there's a lot of difference, even in New England, what abortion care looks like. And if we were to look at what Carrie just described about the rest of the country, these pins would be far and wide between each other. And that 666 miles may actually be more depending on the abortion care that that patient needs.
Such an important point, Kristie. Thank you. So Carrie, we're going to come back to you. You know, Kristie's showing us this really helpful visual of, you know, what folks will have to do to access the care they need where. Can you talk a little bit, Carrie, about how people are overcoming the existing and new barriers that they're facing in order to access abortion care?
Yeah, absolutely. So when the pandemic hit, telemedicine really increased, and telemedicine had really not been used for abortion pills because of an FDA restriction on one of the pills, mifepristone. So let me just say a word. There's two kinds of abortion: procedural and medication. Procedural, which can be used, you know, really throughout pregnancy, is the removal of the pregnancy manually from the uterus. Medication abortion is where you take pills that cause a miscarriage, basically. There are two pills, mifepristone, which stops progesterone from flowing to the uterus, and progesterone is what keeps the pregnancy going. And so the pregnancy begins to shed. The second pill is called misoprostol, which causes contractions and expels the contents of the uterus. You can use abortion pills in the first trimester. The FDA has approved it through 10 weeks, although the World Health Organization says through 12 weeks is fine. You can actually use it later in pregnancy as well, but those are the limits for the FDA protocol of 1 mifepristone and 4 misoprostol. And it's, you know, you expel the contents. So before the pandemic, you could only get abortion pills by going in person to your doctor. But when the pandemic happened, the AMA and some advocacy groups filed lawsuits to have the in-person requirement where you had to go in to get the medication lifted, so that doctors could mail the pills to their patients and consult with them by telemedicine, by phone, by video conference, or even by online form. And so the courts did lift that restriction, and people started to be able to get these pills by mail. So people that are in those abortion deserts that Kristie pointed out, like Northwest Massachusetts or out on the Cape, they could go online and get these pills sent to them directly to their home and take the pills at home. When Biden got into office, he urged the FDA to permanently remove the in-person distribution requirement, which they did in December of last year. So as a result, there are all these telemedicine abortion providers that are springing up all over. Some of them are entirely virtual. Some of them are just like family care providers that can now easily give that service to their patients. And there's an organization called plancpills.org. And if you go on their website, they have like a drop-down menu with each state, and it can tell you who are the providers of telemedicine abortion in your state. Here in Massachusetts, we have about 10 different providers, and the cost is much cheaper than going in clinic. It's as low as $145, which an in-clinic abortion is between $500 and $700. some of these virtual clinics don't take insurance. They often do work with abortion funds. Some of them even have sliding scale fees. So here in Massachusetts, it's legal and we have it. But if you live in Texas, it's not. And so what people in Texas are doing to get pills is they're using an organization called Aid Access, which is based in Austria and run by Dr. Rebecca Gompertz. She serves people in all 50 states. The way it works is that they fill out their information in an online form. Dr. Gompertz reviews the form. If they're eligible, she mails them the pills. And so, and by the way, many telemedicine providers are now sending pills to people in advance of them being pregnant, called advanced provision. And the idea is just have them in your medicine cabinet in case. Now, I want to say that abortion pills are safer than Tylenol. And the only reason they're restricted is because of anti-abortion politics. They're very easy to use. The risks are extremely low, and they're very, very effective. And Kristie may have more to say about that. But I have been arguing that post-Roe is not going to look like pre-Roe because of abortion pills and because people can order it online. Now, another difference, though, is that we have now massive overcriminalization and a huge criminal justice system. And people are trying to go after people that self-manage their abortions by ordering pills from abroad or from online pharmacies, which there's plenty of online pharmacies where you can get these medications as well. So, that the concern isn't so much medical, the concern is legal, criminal prosecution, particularly for the overcriminalized populations like low-income people and people of color, who are disproportionately people that are put in the position of needing to use these kinds of workarounds because of living in states with bans. I'm going to put the Plan C website into the chat in case you're interested. And I will just say briefly also, there are support networks in place to support people who are self-managing. There's one organization called the Miscarriage and Abortion Hotline, and it's staffed by doctors and nurses, and they provide confidential online and telephone support for people who are self-managing abortions. And then there's also the Repro Legal Helpline, which is an organization that provides legal support for people that maybe are running into legal problems because of self-managing.
Okay, so Carrie, this seems like, okay, this is great information. Like you said, pre-Roe, what we're facing isn't going to look the same as pre-Roe. It's going to look different. Can you, one thing that Attorney General Maura Healey did after the Dobbs decision was issue a consumer advisory warning patients seeking reproductive health services about the limited and potentially misleading nature of services provided by crisis pregnancy centers. Can you tell us a little bit about crisis pregnancy centers?
Yes, absolutely. So crisis pregnancy centers are anti-abortion organizations that try to look like medical clinics that offer abortion to lure people in and then give them misinformation about abortion. They often tell people that abortion is dangerous when it's not. They tell them that it causes breast cancer or infertility or depression, which it doesn't. They will often advise people about what they call abortion pill reversal, which they claim that if you take a high dose of progesterone after taking mifepristone, that will reverse a medication abortion. There's no medical evidence to support that. And actually, some of the studies that have been done show it's quite dangerous. The American Medical Association, ACOG, American Association of Obstetricians and Gynecologists, has said that this is an unethical and dangerous practice. But these CPCs are proliferating around the country. There's over 2,500 of them, whereas there's only 700 abortion clinics. And they're heavily funded. We have 29 here just in Massachusetts. And there are organizations like Clearway Clinic that actually, if you go onto your phone and Google abortion services near me, you're likely to get, first couple things are likely to be ads for what appear to be abortion clinics or health clinics, but in fact are these fake clinics. And again, it's part of the sort of on the ground anti-abortion game, is to try to dissuade people from going, or just deceive them and or interfere. They often locate across the street from abortion providers. They have similar names. They often are staffed by volunteers, but the volunteers wear medical scrubs and try to look like doctors. They have ultrasound machines, and they do what's called, they call them non-diagnostic ultrasounds, which means they have no medical value, but they, want to try to say, oh, look, this is what your baby looks like, and do you want to hear the heartbeat? And again, it's to try to, intimidate people from getting the health care that they need. So Maura Healey issued this consumer advisory to warn people against these. Also, the Department of Health has done that. And there are initiatives around the state to try to raise awareness about these crisis pregnancy centers. Out here in Massachusetts, we're passing local ordinances and doing public awareness campaigns to try to inform people about them.
Really, really important. So, it's really apparent that this is a battle about access to information, even. Kristie, turning to you, your consulting firm is dedicated to filling gaps in medical education and clinical training. In your experience, how is medical education impacted by the inflammatory abortion discourse in our country?
Yeah, so I think one of the things that is a misperception of our medical education system is that folks are being trained in contraception, in a lot of sexual health care in general, in abortion care inclusive in that. And that is not happening. It is not something that is a standard in education. Historically, there has been a significant shift in the last 15 to 20 years, especially by a lot of the groups like ACOG that was just mentioned, to mandate education on contraception, on abortion care, and to have that built into especially residency programs for OB-GYN folks, and a similar thing trying to be done in family medicine, where there's at least exposure in training, but for residencies, for people to have hands-on training in abortion care. That is not easy to access across the 50 states. In places where they are not doing the services, people have a harder time accessing the training, even if it is mandated. So in a state where we're hearing now, right, they're not going to be doing abortion care, how does somebody get trained in abortion care? They're going to have to go to another state. That was actually already happening. So the folks that are still doing abortion care are now being inundated, not only with patients who are going to them and flooding their resources, but also by people who are wanting to learn and be trained in that care. And I want to point out too that a lot of what folks will talk about is physicians and how are physicians being trained. But this impacts everybody who's being trained in healthcare. So nurses, advanced practice clinicians, which are nurse practitioners and midwives and physician's assistants, medical assistants, certified nursing assistants, everybody along the spectrum who touches reproductive health care. If they don't see it, they don't know how to do it. And I think it's just going to get worse from where we have been, where they were making strides for improvement in that education. But with the tide turning now, we know one of the things that Carrie and Sara and I were talking about the other day, the fight is not just about abortion care. That's what we're fighting directly right now. But there's also restrictions trying to be put on contraceptive care, on gender affirming health care. So I think that's going to be impacting our clinical education from here on out.
So Kristie, just to follow up, and this is, a question for both our experts, the overturning of Roe was a blow to women's rights to make healthcare decisions for themselves. We're seeing how this is also, leading to other battles. How might this impact the existing issue of gender bias and gender inequity in healthcare?
I think it's going to have a significant long-term impact. We already have a healthcare system that has been designed to pathologize sexual and reproductive health care and to be patriarchal and to not respect, hear, focus on the experience of folks that are not part of research data. So if we are only researching white male population or white female population or people of a certain age or people of a certain class, and we're making all of our decisions based on that, we're already underserving folks. And I think that the disparities are going to keep getting larger, where folks are not being able to access their care and their voices aren't being heard, and that it just doesn't matter, right? So we're going to see that across not just healthcare, but all of the other things that we heard that leading ladies are interested in as well.
And I'll just add on to that. So my concern about Dobbs, I'm definitely concerned about people's access to abortion health care, but I actually think there'll be a lot more harm to people that are seeking to carry their pregnancies to term, because those people will not have access to the care they need when they miscarry naturally, like without not aborting, but miscarrying, or have complications later in pregnancy. Because many of these abortion bans around the state have only narrow health and life exceptions. In other words, 6 states only allow exceptions when continuing pregnancy threatens the life of the pregnant patient. Others only have really narrow health risks, like only if it's physical health, but they don't allow for mental health risks. And many doctors in these states, the penalties for these laws are incarceration, losing your license, being sued civilly for large settlements. And so doctors are being very cautious. So if you have a patient with the septic, for instance, that has an infection, maybe their, their water has broken, they're 15 weeks, infection gets up in there, they're going to need to wait until you're dying before they can give you that care. And if you go and look at the media, there's story after story of doctors feeling they can't provide the care. Just this morning in the New York Times, there was a situation where a woman, I think she was 10 weeks, no wait, maybe it was 15 weeks pregnant. She was in Louisiana. She had a fetus without a skull. The fetus would not be born alive, or it would be born and just die right away. And she couldn't get it. She couldn't get care in Louisiana. She had to travel to New York City to get the care that she needed, the abortion. She was only 15 weeks along. And I think we're going to be seeing more and more, or, I mean, at least she survived. I don't know, she had the money to travel to New York. But what about people who don't have the time to travel out of state to get the care they need? I think we're going to be seeing, and this happens around the world and where abortion is illegal, we are going to see people dying. We're going to see people with significant health problems resulting from the lack of access to care. And, again, it hurts, not only women that want to have abortions, but women that want to carry pregnancies to term.
Mm-hmm. Yeah. Especially, Carrie, I'm so glad that you brought that up. We have the highest maternal mortality rate in our country already before we had this problem, right? And that is one of the things that I'm hearing, especially in my community, is that discourse about what do we do? How do we make clinical decisions? Do we have to go to a committee? What do the lawyers think? Healthcare is becoming more and more regulated just by this one decision because folks don't know out of fear what decisions to make. I'm really anticipating a new book. I don't even know the title, but there's a sociologist out of California, Lori Friedman, who studied Catholic healthcare systems and folks who wanted to do abortion care and were willing when they entered residency, but were unable to do so when they finished residency. And that book is called Willing and Unable. It's about 12, 15 years old at this point, but she's doing a new research project and coming out with a book soon that's going to address even more of what Carrie, I think, is talking about, is this, how is healthcare not delivered from clinical decision-making, but more this fear-based, religious, legal framework where lay people are making decisions.
And just to add also, Kristie mentioned that maternal mortality rate is quite high in the United States. For Black women, it's 17 times the rate of white women. This is a racialized issue. This is way disproportionately harming low-income women and women of color. And, you know, rather, the states that are banning abortion are the same states that have the highest maternal mortality and do the least help babies once they're born, have the highest child poverty rates, cutting food programs for children. And so they're forcing people to have babies in situations where it's dangerous. And then once the babies get there, they're not supporting them. It's by design.
It's by design. So let's look at the other end of the spectrum. We were talking about healthcare inequities. Let's go to health education for children. This is for both experts. What do we see as the jobs impact on the prospect for health education for our young people?
Carrie, do you want to start?
Sure. Or you. So, Sarah's referring to sex education for K-12 students and where we stand in this country. Despite the fact that we have, most kids in this country learn about sex by watching pornography. In schools, most students are getting abstinence-based sex ed, which is basically don't have it. It will give you diseases and make you unmarriageable if you're a woman. There is comprehensive sex education, but it's very unevenly distributed around the country. Often sex education I don't know of hardly any that talks about abortion, but often, comprehensive sex education will talk about contraception and ways to prevent pregnancy and protect yourself from STDs. Abstinence-based education will just say, don't do it. And, sort of use scare tactics. It's, here in Massachusetts, we don't have very good sex education. Schools can do whatever they want. They don't have to do anything. There is currently pending legislation that we've been trying to get passed for years called the Healthy Youth Act. What that would do is say, if you offer sex education, it has to be comprehensive. It would not require that sex education be taught. I teach at Smith College. I get a lot of Massachusetts kids that come, students, young women, and I always ask them, okay, what kind of sex ed did you get? And it's astounding to me how many of them get abstinence-based sex ed. I mean, one that just comes to mind is Belchertown, Massachusetts, right across the river here. She got abstinence-based. She didn't know anything. And so when kids don't get good sex education from, school or from their parents, which is often the case, they go online. And that's a mixed bag. And, as far as just learning about what sex is, like I started, often they're looking at pornography. And that is the most dysfunctional, violent way to learn about what sex should be and, what consent is and what safety is, using a condom, preventing pregnancy, preventing STDs. And so I'm a big supporter of the Healthy Youth Act. I actually think we need a broader law that would require all public schools, and quite frankly, I think private schools, to teach comprehensive sex education.
Mm-hmm. That was so great, Carrie. Like, as a sexuality educator, I'm like, yes, thank you. What I would add is that there are a couple of things that we are just societally are additionally challenging, right? Like sexuality education has not been good anywhere in this country for a very long time. There are good programs. They typically happen outside of a traditional educational system, but they are not within the structured educational systems comprehensive or value-based in the way that the value is people are getting accurate information, medically appropriate information. So I'd say that the additional challenges are, yes, pornography is a significant educator of our youth, but also just there are not many limitations on what is available for information on the internet. there is something going around our community right now because of abortion and what's happening post-Dobbs about, can there be these crisis pregnancy centers or other institutional institutions that are putting out misinformation, and do they get the same weight as an organization like mine that's doing abortion care? So can we put a label on that we are an abortion provider and they don't do abortions, right, for crisis pregnancy centers? But I'm going to suggest that that's across the board. So we're working with Google right now to try to say, like, you need to have accurate information, and where you know that there is misinformation, you need to take that down. So again, with the disparity in who has access to what across the country, education is part of that, and what information they're getting. One of the saddest things working in a clinical setting is seeing people who are 20, 30, 40, 50 even, and older. They don't know their bodies. They don't know their body parts. They don't know how they work. They don't know how they get pregnant. They don't know why certain things happen. And they have a lot of questions when they come, and they may even have some barriers to receiving information because of stigma or misinformation that they've been given, but they've been given it by a system that they value. So they're like, do I trust you, or do I trust my church or my grandma, or, you know, whoever that may be?
Thank you, Kristie. So earlier, I think when we got started, Carrie mentioned this week, Senator Lindsey Graham introduced a bill to create a federal ban on abortions at 15 weeks. Carrie, can you tell us a little bit about, help explain how this is a departure from prior strategies, and how this is likely to play out in Congress? What should people be keeping their eyes on?
Yes, absolutely. So that happened yesterday. Lindsey Graham introduced a 15-week abortion ban with very narrow exceptions for threats to life. So the Dobbs decision, I think, opens the door to a nationwide ban on abortion. The decision, I think, is just likely to be the beginning of what this court has in store for us. The court mentions unborn human life, that phrase, or unborn human beings, 23 times. And the anti-abortion movement is now teeing up a case to establish fetal personhood in order to ban abortion nationwide. In other words, what they are trying to do is to get fetuses to have constitutional rights to life, so that states like Massachusetts can't protect abortion rights. And I just published a piece with Ms. Magazine. It went up today. Catholics for Life in Rhode Island have filed a lawsuit, a writ of certiorari, a petition to the Supreme Court to hear a case where they are challenging the Rhode Island law that legalizes abortion. And their argument is that this law violates the right to life of preborn human beings. And whether the court will take that, I don't know. But I think the fact that they 23 times used the phrase unborn human beings, they were inviting that. And while I think that Lindsey Graham's bill's not going anywhere, if the Republicans get the presidency in both houses of Congress, they will pass a nationwide abortion ban. But I think more likely will be that the Supreme Court will ban abortion nationwide. Now, the irony is that the Supreme Court and Lindsey Graham has been saying all along, oh, we want it to go back to the states. But now, of course, they've turned on a dime and they're now saying, oh, we want to ban it nationwide. And so, and I don't think, by the way, it's not just about abortion. They're also going after contraception. If you read Clarence Thomas's dissent in Dobbs, he explicitly says he thinks that the Griswold decision was wrong. Griswold was the 1965 Connecticut decision that legalized contraception. And then there was one a couple of years later, the Eisenstadt versus Baird, which legalized it for single people. Griswold was for married couples. Eisenberg legalized it for single people. And he said he thinks that we should overturn that and let states regulate contraception as well. And the thing is, even before that, a lot of anti-abortion people say that hormonal contraception is a form of abortion. Things like emergency contraception, which is just a triple dose of pill, basically. They think that hormonal contraception more broadly, IUDs as well, that they are abortifacients. And so even without the court overturning Griswold, states could begin, and have already threatened in some cases, to begin to limit IUDs and other kinds of contraception. But I think that, that's their goal. I mean, I really think that, and now I'm getting into my own personal opinion, that they don't like people having sex outside of marriage and without consequences. And so, they're coming from a religious perspective. I mean, the position of the Catholic Church is people shouldn't use contraception, that they should only be having sex for procreative purposes within the bonds of marriage, right? And so they are trying to impose these religious beliefs on everybody. Evangelicals as well. Interestingly, there's a case that just got brought in Florida by a synagogue, by a Jewish group, saying that the 15-week ban on abortion in Florida violates their religious rights, because their religious beliefs are that the life of the pregnant woman takes precedent over the fetus, and that she gets to make that decision. And so they're challenging that on First Amendment religious freedom grounds, which I think that's a really interesting argument, because of course the court's been very strong on religious rights. So they'll be
we'll be keeping a close eye on that one, Carrie. I mean, that's a very, very interesting case. For all of our audience members, I know when the Dobbs decision came down, tremendously distraught, but explaining to my children, my daughter, don't worry, we have good laws in Massachusetts that are going to protect us. This is extremely concerning. Kristie, do you want to try and zoom in a little bit? What would a 15-week ban on abortion nationwide mean for people trying to access care?
That's a great question. I think I'm going to share my screen again, just to give us another visual. Not sure if it's going there. Okay, let's see. Yes.
Okay.
So one of the things that I would like to point out, here is, I don't want to say that this is not negative, a 15-week ban, but I would like to point out that the majority, and these are Massachusetts numbers, but the trend across the country is similar, that the majority of abortions happen in the first trimester or before 13 weeks. Here with our 2020 data in Massachusetts, that was 91% of abortions. Before 19 weeks was 98% of abortions. And in the state, we had 329 that were after the 19th week. Now, for those 329 people, that's very important. They needed to have that abortion for whatever reason that they needed to have that abortion. But I will say that the majority of abortions do happen before 15 weeks in the country. Now, saying that, I think that can also be a part of a challenge in that it can be data that's like used against us, right? So it's like, well, then we don't need it after 15 weeks, let's just do that cutoff. But people have abortions for different reasons, and all of them are valid, and they need to be valid for as long as the people need access to that abortion. So I think that nationwide, it is going to have a significant impact on a significant number of people. But if it were to be at 15 weeks across the board, there should still be access for the majority of what abortions would be. But there are complete bans in some states, right? Or there's the 6 weeks when folks don't even know that they're pregnant yet. So I think I would just want to reiterate, most abortions do happen before that 15 weeks, but those of us who are pro-choice or pro-abortion being an option and pro-abortion, that it shouldn't matter the gestational age. If somebody needs an abortion, it's between them and the person that's going to give them the abortion, why and how they get that. And so the other thing, let me also say there, when I was talking about training earlier, so medication abortion, as Carrie described, is a medication and is approved up until certain gestational age in the country. And after 15 weeks, it pretty much needs to be a procedure of some sort. And if folks don't have the training or the skill set to do that, it makes it less accessible. So I would say for every week past 15, you are looking at access being harder and harder, because finding the folks that have the skill set and have the team, right? Because it's not just a physician, it's the entire system. If they don't have a skilled team to do that, it's going to be harder to have access to.
I also just want to add, 54% of abortions in the United States are by medication. And people that have abortion later in pregnancy, it's often because of health conditions that develop or are diagnosed later in pregnancy. Our restrictions on abortion, like the expense, the distance, the waiting periods, push abortion later in pregnancy. In countries like Finland or many European countries, abortion happens much earlier, and it's like 90% by medication. And it's because they don't have barriers and it's publicly funded. So, again, late abortion is by design in this country.
Mm-hmm. I'll add to that, Carrie. You talked about crisis pregnancy centers. So, right, like I just heard a story today. We had a patient or somebody who somehow interacted with our health system. They had a pregnancy test 7 weeks ago that was positive. And they went to a crisis pregnancy center and they told them that they were 5 weeks pregnant, right? And we were like, but you had a pregnancy test that was positive 7 weeks ago. So let's like try to figure out some accurate information, right? So the goal of crisis pregnancy centers is to get people farther into a pregnancy so that they don't have an option. So that's one point. And then, oh no, I lost the other point.
Maybe while you're thinking about that a little bit, Kristie, in our conversations leading today, one thing Carrie and Kristie were able to educate me about was the issue of these Catholic healthcare systems, Catholic run hospital systems. Can you tell us a little bit about that and how that is already impacting and will continue to impact care?
Yes. And the one thing I did remember, so I said that I had come from Illinois. So I just have friends back there and they're telling me with where we are currently on the ground post Dobbs, right, that the places where they have access to abortion, they have 4 to 6 weeks waits now, right? So that also is pushing patients who know earlier in pregnancy, maybe 5 or 6 weeks, they have to wait 4 to 6 weeks now to get an abortion appointment. So by design, Carrie, is it's a great term.
Yeah, I also just wanted to say, I just popped in the box an interview I did with a student who's at a college near Boston who was looking for an abortion clinic. And she knew about CPC. She was a pre-health student. She was only 18. She was a first-year student. Her boyfriend was a little older, president of the student council, and they went online to search for an abortion clinic, and they both looked through the various websites and found a clinic. And when she got there, she realized it took her a while, but it was a crisis pregnancy center. And so I interviewed her, and this is the interview. And it was similar, Kristie, to what you said. They said she was much, actually in her case, they told her she was later. They did a non-diagnostic ultrasound and she told her she was more pregnant than she was. And I was perplexed by that because I'd always heard they tell you you're less, so you think you have more time. But what happened was they then took her into a room and they showed her a big fetus. And they said, look, this is what your baby looks like. And I think they told her she was later along because they wanted to show her a bigger fetus. And but or they just don't know what they're doing, which actually that's probably what it is. But she was very traumatized by this experience. And when she did finally get to a real healthcare professional, she said she was very distrusting. And it undermines patients' trust in medical providers. When they go to somebody they think is a provider who's wearing a lab coat, who has, did ultrasound machines and who's rubbing your stomach, and touching you intimately, collecting your personal medical information, and then you find out it's all fraudulent. And these centers don't charge anything. And so they collect your medical information and they're not bound by HIPAA. HIPAA only applies if you're filing insurance or you use Medicaid. And so they share your personal private information with the anti-abortion movement, and in states with bans could share it with the police. I've written about this a lot for Ms. So the sort of surveillance of pregnant people and then sharing of private medical information. Like this young woman gave them her mother's name and telephone number. And she had not talked to her mother about being pregnant. She was kind of horrible. She was really worried they were going to call her mother and tell them. So he's actually filing a complaint with the Attorney General now, which I encouraged her to do, and she's doing it. So anyway, if you're interested in that story, I've put it in the box.
Wow. Wow.
Sara, I am going to talk to the Catholic healthcare system.
Oh, thank you, Kristie. Thank you.
Yeah, for a second. So I'm just trying to find. Okay, so here's my presentation again. Sorry. Oh, this is an example of our local crisis pregnancy centers to HealthQ. So these are 3, just to say that they market the same as everybody else, right? They are a little bit deceptive. And this is the numbers in the surrounding states. So we have 20 abortion providers in Massachusetts, 29 crisis pregnancy centers. And then these are the surrounding states with their numbers. But for Catholic healthcare, this is just to give an introduction, because this could be like a whole topic in and of itself, right? But there in the reproductive health world is a significant following and research being done about the Catholic healthcare system and the barriers that is creating for people accessing sexual and reproductive health. So everything that Carrie and I have been talking about that are barriers, and specifically because they are typically tied to a religious belief, are already being enacted in healthcare systems that are owned and run by Catholic institutions. They have something called the Ethical Religious Directives, which if they are a Catholic institution, they have to follow in their institution. And they do restrict contraceptive use, prescription, and abortion care. So just to give a visual of like what that looks like across the country, I pulled up the map from this article, Bigger and Bigger, the growth of the Catholic healthcare systems, to show like a lot of folks think, Washington State pretty progressive, has a lot of access, their healthcare they should not have many issues with, but 41% of their hospitals or hospital beds are Catholic owned. So even though they do have good sexual and reproductive health care in the systems that are not the Catholic institutions, they are being more and more gobbled up by Catholic institutions. So I said that they have this ethical religious directives that they need to follow. A lot of folks will have this disappointment. I don't know who to trust after experiences. I've heard of stories recently where people wanted to have like a sterilization, a tubal ligation after a delivery where they were having a cesarean section. And they were told, I'm sorry, I can't do that because we're in a Catholic hospital. Or I'm sorry, I can't do that because your insurance is a Catholic insurance and they will not allow that. It's not covered by your plan. So it's not just abortion care, it is also contraceptive related, and is something that's significant across the country. So yeah, I'll stop there. And training too. That book that I was mentioning earlier, The Willing and Unable, was about they couldn't get trained to do things because of the ERDs.
Just popped in the box an interview I did with a woman in Michigan who was pregnant. She didn't know that they wouldn't give her a sterilization, and she was like 8 months pregnant. She finds this out, and basically they said, well, you can just come here, deliver your baby, we'll sew you up, and then you just go somewhere else and have them cut you back open and sterilize you.
Mhm.
And you know, so they don't advertise that they don't do sterilizations often. It's very hard to find out. You may or may not know. And so this was an ACLU filed a lawsuit against this Catholic hospital because of this. And so this piece was about that. It was last year that I did it. They also, if you're sexually assaulted and you show up at the emergency room of a Catholic hospital, they won't give you emergency contraception.
Mhm.
So, and when Catholic hospitals merge with non-Catholic hospitals, often the Catholic standards predominate, that they take control of the whole institution.
I mean, this is you know, such an important thing for us to keep our eye on. You know, even following this relatively closely, this was new information for me. So really, thank you, Kristie and Carrie. This is really disturbing, but really, really important for us to be aware of and watch. So let's get to the hopeful part of, before we go to our questions, let's get to our hopeful, action-oriented part of our conversation. Kristie, Carrie, you are experts, you know, everyone, you know, wants to know, what can they do? Where is their time, their effort, their dollars? What is the best thing we can?
Uh-oh, it sounds like Sara has frozen.
Yeah.
So maybe somebody can text her and oh, you're back.
Back.
Sara, you froze for a second, but.
Oh, I'm so sorry. Okay,
Yeah,
so
that's okay. But I got your question. Yeah.
you got my question. Okay.
Yeah. So we live in an amazing state. Back in 2018, after Brett Kavanaugh got on the court, we passed a law called the Nasty Woman Act, which got rid of our archaic pre-Roe ban on abortion. Then we fought tooth and nail, and in December of 2020, we passed the Roe Act, which expanded access to abortion. We got rid of parental consent for 16 and 17-year-olds. We were the first state to do that. Other states had followed. Illinois has removed some of their parental barriers. We then, right after Dobbs on July 29th, we passed a really amazing comprehensive law that did some of the things that the Roe Act didn't do, in part because we were in a different time. And also we had to overcome the governor's veto because he vetoed that act. Baker vetoed it. The new provision that just passed, it requires that insurance cover abortion and abortion-related care without cost sharing, including copays or deductibles. It requires all Massachusetts public colleges and universities to provide medication abortion at campus health centers. It just goes on and on. There's all kinds of amazing provisions in this law. But the thing that's particular, so Massachusetts also provided a shield for providers that care for people from out of state, and so that they can't be sued, and people from out of state can't come and use Massachusetts courts to try to prosecute them or to file warrants to get access to information or to attack their professional licenses. And a few other states are doing that. Connecticut's done it, Illinois has done it, California's done it. But the thing that Massachusetts did that no other state has done, and it's a little bit of gray area, is that they are protecting telemedicine providers in Massachusetts that provide care to people in states like Texas with bans. So they're defining telemedicine to be occurring in the location of the provider rather than the patient. And so people are now preparing to begin to offer telemedicine from Massachusetts to people in the states that have banned abortion. This is huge. It means that they can get care within the medical system from their homes. Rather than having to just order pills online or order it from providers outside of the country. And then they can get follow-up care from these providers. Now, there's still legal risks, although no states yet, only 3 states actually criminalize self-managed abortion, but there are prosecutors that will use other laws to try to go after people who are self-managing, but it's often very hard to track people who are doing it because it's very early. And, the biggest risk is digital surveillance. And so the movement's working really closely with people about how to search for abortion pills online and get this care in a secure fashion, like use virtual private networks and other things. But so Massachusetts is, I mean, this Dobbs decision has really mobilized people in Massachusetts to work to expand and protect rights. But outside of that, it is incredibly mobilizing people for the elections. And by the way, I'm just going to pop in the box 3 key organizations in Massachusetts that are working on abortion rights: Reproductive Equity Now and Planned Parenthood Advocacy Fund of Massachusetts. I'm actually on their board, by the way. And then they have their Beyond Roe agenda. So this is the agenda that was developed for this recent act. The act hit a lot of the points, but there's still more, like the Healthy Youth Act. But in addition to this, the November elections are absolutely key. And in particular, we need to pass the Women's Health Protection Act at the federal level to guarantee abortion rights across the country. And to do that, we need to hold the House, and we need to pick up 2 seats in the Senate so that we have 52, so that we can get rid of the filibuster and pass voting rights is the most important thing, but also the Women's Health Protection Act. And so I'm putting in the key races to focus on with regard to the Senate. And if you go to Swing Left, they will have information about all of these candidates, plus the House candidates that are really key. But these are the 9 Senate races where it's either close or to hold, or we have a good chance of picking up the seats. All we need are to hold the 4, Georgia, Arizona, New Hampshire, and Nevada, and then pick up Ohio, 2 of Ohio, Pennsylvania, North Carolina, Wisconsin, and Florida. Those are our best shots. And I think that finally now Biden's come out in favor of removing the filibuster. I really think that if we can do this, we can overcome the Sinema and Manchin problem and the resistance to getting rid of the filibuster and pass the Women's Health Protection Act. So those are a few of the things as far as what we can do on the ground. The only other thing that I'll mention is that we also have abortion funds here in Massachusetts, which are organizations that raise money to help people access abortion health care. And more people are coming from out of the state to get care. So out there in Eastern Mass, it's called the Emma Fund, and the link's in the box. Also, there's the Bridget Alliance, which is a national organization that helps people travel for abortion health care. So those are the few of the organizations that I really recommend that people support if they want to help individuals who are trying to get the care they need, including having to travel or other afford expensive later procedures.
Kristie, what can people do?
Thank you. So Carrie, I'm agreeing with everything she said. The vote and really being proactive about finding candidates to be actively engaged and continuously running is something that we need to focus on. The folks that have implemented where we are in this current time to have abortion being challenged have been at this for 50 years. Right. So we need to keep at that same pace and involvement as they have been. So echo everything, vote, 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 talk with folks. So if people are voting in other states, educating them, they may not be as aware of what's happening, although after Dobbs it's hard not to some way, but all of the impacts, right? Like if somebody's like, I don't want to talk about abortion, then talk about something else, because we keep saying this is not just an abortion issue, right? It's just where the focus is right now. I would say definitely supporting the funds. So I know that Sara dumped the whole bunch that we have here in Massachusetts into the chat feature. The Ties for Reproductive Justice Fund, they have a donor link, but I somehow misplaced it and their website is not quite fully developed. They are starting to be a 501c3 just this year, and they are working on doing practical support. So the majority of the funds are set up to help people financially pay for abortion, and practical support means helping to pay for travel, coordinate childcare, and pay for childcare, like all of those logistical things. So they're coming, and I will get that information out to leading ladies. sexuality education, really be an advocate for that. I think we had a representative, a state representative come and visit our office, and he was like, what can I do for abortion? I was like, look, I think we've got that covered right now. I need you to advocate for the sexuality education. Because we knew that that bill was going through the system that, like Carrie said, has so many great features in it. Support the funds, pro-choice candidates, support the disenfranchised and advocate. So there's a lot of stigma. The folks that are, I would say, our colleagues and friends at Boston Medical Center and Boston Children's Hospital are being, and this can again be an entire different panel, but they are being targeted and harassed right now because they offer gender affirming care. And those of us who work in abortion care are used to being targets, and we have security procedures and protocols and trainings that people in, you know, the real world don't even think that we would have to be prepared for. But this is a really hard time to be in healthcare and delivering stigmatized care that is the face of every day's target on the news. So being aware of all of us that are out there doing it and trying to have our backs and being supportive of that. And also for legislative, protecting those things as well. So one of the things that we're still advocating for is how private can people's information be? So if somebody is registered as a clinician in this state, their personal address is attached to their license, is attached to a lot of things that are registration things. And how do we protect that in a world that is so focused on the internet has everything, right? And protection or privacy is not what it used to be. So helping us fight for those things. And then just keep an eye out, like the Catholic healthcare, when Sara was like, I had no idea. I've been doing abortion care for 30 years. I've been working in, you know, this real battlefield, I consider it, for 10 to 15 years. And my mom just sent me an article saying, I thought you would be interested in this, about a religious healthcare system taking over our local, where I grew up, healthcare system, and it was a birthing hospital. And my mom had no idea that I had any knowledge of it. And I'm like, Mom, these are the people I work with. So just, you know, being aware of what's happening in your own area and keeping the dialogue going so that we are on top of things as they're unfolding.
So important. And this is where leading ladies come in. Thank you.
Mhm.
So we have a few questions here. Elaine had asked, how likely is it that Plan B and the medication abortion drugs can be available to those in jurisdiction where it is illegal?
So just to clarify for folks, Plan B is emergency contraception, which you take before you're pregnant, after you've had sex, condom breaks, sexual assault, whatever. You take it within 5 days and it prevents pregnancy. Whereas medication abortion, you take after you're pregnant to end a pregnancy. And so emergency contraception, again, could potentially be targeted by aunties, but it is over the counter. It's available, although it's kind of expensive. The wonderful thing about the Massachusetts law is that it created a statewide standing order for both prescription and over-the-counter emergency contraception, allowing pharmacists to provide it and have it covered by health insurance. Also, it allowed for vending machines with emergency contraception. So like Boston University now has a vending machine. They're charging $7.25 for emergency contraception. It's normally $40 at the pharmacy. So it's subsidized. And so making that more available is absolutely critical so that people can just prevent pregnancy. I mean, pills more generally need to be available. There's an application now with the FDA for an over-the-counter birth control pill. And we're all really pushing to get that approved so that birth control pills can be on the counter next to Advil and Motrin and pads, right? It's key. We need to prevent pregnancies so that people don't have to have abortions. But in states where there are restrictions, they don't like these things, and they use religious exemptions to refuse to prescribe or sell emergency contraception. But people can get these things online, both medication abortion and emergency contraception. And Where before Roe, when there were no pills, people were using coat hangers or whatever, that's not necessary now because of abortion pills. Now, yeah, if it's later in pregnancy, people may do dangerous things, but pills are so safe and so accessible. And so I think that's going to be a real key for people's access post-Roe. And by the way, around the world where abortion is illegal, using abortion pills has dropped maternal mortality and death from illegal abortion precipitously. And by the way, you can use misoprostol alone. You don't need mifepristone. And misoprostol is actually quite cheap. It's the drug that you use for ulcers. You can get it in any pharmacy. You need a prescription, but people, it's over the counter in Mexico. And in many countries where abortion is illegal, women just use misoprostol. And again, it's quite safe. And it's illegal, but many countries don't have such a hyper criminal justice system. So women just get the abortion using these pills.
Thanks, Carrie. So another question, are there Catholic insurance companies that follow ERDs?
I don't know that they necessarily follow the ERDs as far as like a strict set of guidelines, but there are Catholic insurance companies that severely restrict what they will consider and cover in their contracts. So they will not cover contraception. They will not allow medications that were made from products that were researched or created from things like research in pregnancy tissue. So because they don't support abortion, they won't support something that was done with research of fetal tissue. So there are a lot of things that their insurances, and not just related to reproductive health, yes, are impacted by because of the Catholic philosophies, if you will.
All right. Thank you, Kristie. And so thank you for the questions. Anyone else have any questions as a result of this really rich conversation? All right, so we have our action plan. We know what we need to do.
Can I speak one moment, please? I'm Sandy McKenna. I'm a friend of Judy's. I belong to a group called Force Multiplier, and we have been able to give millions of dollars through donations from people all across the country. And all of the candidates that we support are all Democrats, and they all are pro-abortion. So you can find them very easily. I was trying to put them in the chat, but I'm not on my own computer, so I'm having a hard time doing it. But it's Force Multiplier, and it may say US under it. But I just Googled it. If you put in Force Multiplier US, you'll find them very quickly. And there's a slate of candidates coming up just next week to give donations to. But we're supporting 16 new members to the House and 8 members to the Senate. Half of them are already in the Senate. The other half are to get into the Senate. So you may want to look at that, and if you're looking for ways to do things politically, this is a terrible, terrible problem. Even much worse than I thought it was before I got on the Zoom call. The Republicans are really trying to push an agenda that is just immoral. So,
yeah, and I'd just like to add that, if we can remove the filibuster, we need not just the Women's Health Protection Act, we need voter protections. We need to pass the Voting Rights Act, because we need to pass electoral reform and court reform, because our democracy is severely under threat. I wrote a piece at one time and I showed that bans on abortion and voter suppression went hand in hand. The states banning abortion were also suppressing the vote. And one argument that I make in my work is that this is the last gasp of white supremacy. there is an attempt to try to disenfranchise African Americans and people of color and force white women to have more children. And I'm not saying this, I mean, I deeply researched this. And you see this in the Trump, world. And, the people that attacked the Capitol on January 6th, many of them are deeply involved in the anti-abortion movement. And racial politics are absolutely at the heart of the anti-abortion movement. It's about an attempt to maintain white supremacy. And I think that we need to get the vote out, and we need to get enough power in Congress to be able to pass structural reforms to ensure our ongoing democracy. 64% of people in the United States support Roe. 61% support abortion in most circumstances. But if you look at the electoral map and the red and the bans, the majority of the country is going to ban abortion. So we are not living in a democracy, and we're sliding towards a Christian nationalism, quite frankly. And so I think this is such a critical time that people get out and organize and vote and inform each other. If you're ever going to do it, now is the time to do it.
Amen. Well, thank you, everyone, for joining us tonight. This has been extremely informative, and Leading Ladies certainly will be, if you haven't, you should read the newsletter that came out today that the fabulous Judy Klein writes every week, and it is about sex ed in schools and touches on some other things. So we've talked about Plan B and Plan C and in previous letters, but if you are not on our mailing list, go to our website, leadingladiesvote.org, and sign up, and you will get a weekly newsletter from us that is extremely informative. And there's always an action item at the end, and it's something hopeful. So thank you, everyone. Does anyone else have any last minute question or comment?
All the links and information that are from the chat, will those be made available somehow subsequently?
Yes. This video will be on our website, and we will collect this information and make it available also on the website.
Great, thank you.
You're welcome. All right, well, thank you, Sara and Carrie and Kristie. It's so wonderful to be a part of this coven. Tribe is used too often. I'm going to say that we're a fabulous coven of intelligent women that are working really hard to just pick up where the mothers before us, it took, what was it, 70, 80 years for the right to vote, and many, many years to make abortion legal. And we can't just sit back and expect anyone to not to continue to work hard for this. You can't take your eye off the ball. So thank you so much for joining us. Thank you, everyone, for joining us tonight. And look on I'd say check the website probably tomorrow, but definitely look for the email if you're on our mailing list, and if you're not, please join the mailing list. Thank you so much.
Thank you very much.
Thank you so much.
Very well done.
Bye-bye.
Thank you.
Thank you.
Talk
Thank
to you.
you.
Bye-bye. Thank you so much.